I was asked to talk about the relationship between the emergency department and outpatient care settings. I'm actually going to venture a bit beyond that and talk about the relationship between the ED and several aspects of the healthcare system. And I'm going to have two parts to this talk. The first is talking about how the healthcare system impacts emergency department use, or what can we do before the patient comes to the ED. And then, turning the arrow the other way, I'll talk about what we can do after the patient seeks emergency care, or how the ED can best relate to the rest of the healthcare system. And in doing this, I'm going to refer to two conceptual models, the individual model and the systems model, which I want to illustrate with a case example. This is a 30-year-old woman who came to Oregon Health and Science University's emergency department some years ago with a chief complaint of vaginal bleed for several weeks. She had a past history of ITP. She had stopped taking her medication several months previously on her own without any discussion with her physician about that, and the bleeding started. On exam, she was pale but otherwise stable. Pertinent positive was a slow vaginal bleed, and there was an incidental note of limited range of motion in the right elbow. Labs were significant for substantial anemia. So the individual model of why she's in the emergency department is that she's a non-compliant patient. She stopped taking her medications, and she's made a poor choice about provider coming to an acute care setting for a chronic or at least subacute problem. But it happened that we were doing a small qualitative research project when she came. One of our then residents, later research fellows, Breyer Ertzberger, interviewed her and asked her, why did you come to the ED? And her story was that she had been on the OHP, or Oregon Health Plan, our Medicaid expansion program, and she lost her benefits. And she could no longer afford $600 a month for her medication. As a result of stopping it, she bled into her elbow, had a frozen elbow. She'd been working in a restaurant. Now she could no longer do the work, so she lost her job, became unemployed. Her kids were coming home from school crying because they were being teased about the ragged clothes they wore. And to quote, "It's an awful lot of stress, and it's really unfair. It's hard on me, on an adult, you know, but what they put the kids through, it's just crazy. And we were an honest, hardworking family. Then I lose my job, and all that stopped. I mean, it all just stopped. And you know, I lose the car. I'm evicted from the house. The gas gets shut off. The water got shut off. The electricity. You know, honestly, there was even like suicidal thoughts. If like I just fix the gas heater and we all just fall asleep and not wake up the next day, and we wouldn't have to go through this anymore." And when you listen to that story, you understand the systems perspective of emergency department use. The ED is not the problem, but it's a canary in the coal mine, a way of understanding what's going on with the system that drives this woman and so many of other patients coming through our doors. Long-standing systems model of medical care seeking in general is the Anderson and a Day model. This is not a slide you'll be able to read from the back, but it talks about population characteristics that drive health behavior, which in turn drives outcomes. And population characteristics include predisposing characteristics like demographics, patient age, gender, things like that. Enabling characteristics like personal or family resources like insurance, social support, having a regular source of care, community resources like what health services are available. need of care, both the patient's perceived need of care and need of care is measured by people in the medical care system. These all drive health behavior, which includes personal health practices like diet and exercise, and also use of health services, including ambulatory, inpatient, and of course, the emergency department. And these in turn drive outcomes that include both health status and satisfaction with care. So I'm just going to pick a few of the characteristics of the model for which I'm aware of some research pertaining to emergency department use to kind of illustrate how this can be applied to the ED. So let's start with the impact of a regular source of care on ED use. This slide shows for 3 different payer groups, comparing those with a usual source of care to those without a usual source of care, where the outcome is the proportion of people who have at least half of their ambulatory visits in the ED. And it kind of illustrates the popular wisdom that people without a usual source of care come to the ED more often. But it's not quite that simple. This slide has a somewhat different outcome, subtly different. It's the percent of people in each age group who have had at least one ED visit in the last year. And you can see for people under age 65, there's no difference. And for people 65 and older, the difference is the opposite direction of what we just saw, that people with a usual source of care are more than twice as likely to have had an ED visit in the last year. Now, I can speculate about why that is, and there's some data to support the idea that when you have insurance, and everyone over 65, pretty much everyone has Medicare, then you're more likely to connect with a primary care provider if you're sick. And sick people are more likely to use the ED as well. So that would explain this, but it illustrates the complexities of what would seem like a simple association. So now let's talk about the relationship between insurance status and ED use. People on Medicaid use the emergency department at the highest rate, about 82 visits per, is that 100 people per year? I think so. Yeah. And the uninsured use the ED at just over half that rate, same rate as those on Medicare. The commercially insured use the ED at the lowest rate. But that's probably not the most interesting question. I'm more interested in what the panel was talking about earlier, which is when you give people insurance, what does that do to their use of the emergency department? This was a nice review that was in the New England Journal a month or two ago that shows data from 5 studies. The Oregon Health Study, which showed a 40% increase in ED use as people became eligible to apply for the Oregon Health Plan, and 4 other studies from Arkansas and Kentucky, Tennessee, Massachusetts, and I'm not sure where that one's from. And you can see that each of them shows a drop in ED use, but the magnitude of the drop is extremely variable. Summers has a great quote here, which is, if you've seen one state Medicaid program, you've seen one state Medicaid program. He lists some factors that may modify the association between gaining insurance and ED utilization. For example, young healthy people who newly get insurance probably have access to primary care outside the ED and lower need for health care services in general. In terms of insurance plans, we talked earlier about the low reimbursement rate for primary care under Medicaid. And as a result of that, the network adequacy, the number of primary care providers who will see Medicaid patients, is pretty low. So if your expansion program is Medicaid and pays at Medicaid rates, those patients may not have any place to go other than the ED. And Oregon has very limited primary care availability, which could partially explain the results of the last slide. On the other hand, if the expansion is improved access to commercial insurance, then higher payment rates, better network, and you might see the sorts of drops we saw in some of the other studies. Here we look at community resources. This is a study that we did in Oregon several years before the OHP expansion. The Oregon Office of Rural Health has divided the state into a couple of hundred primary care service areas, and we looked at ED utilization for Oregon Health Plan enrollees in each of those service areas with case mix adjustment, and found more than a 10-fold variation in ED utilization rates, the red line in between the confidence interval bands. We didn't have a lot of data on the different communities that were in that study, but we looked at what we did, and we found that communities with better primary care capacity had lower ED use. Communities where the nearest ED was further away also had lower ED use. As one of the research team said, if you don't build it, they won't come. I'm really working hard to tell some jokes since it's late in the day. I'm clearly not succeeding. But, Cunningham did a similar study using national data from the Robert Wood Johnson Community Tracking Survey, and also found higher ED use in communities with more EDs, as well as communities with longer waiting times for appointments, lower managed care penetration, and counterintuitively, in communities with more safety net clinic capacity, there was more ED use. Social factors, housing. No surprise to the Camden team, I'm sure, that the homeless use the ED at about twice the rate of those of us who have housing. This is a study we did in partnership with a Medicaid managed care organization in Pennsylvania, where we looked at patients' ED utilization rate, adjusted for patient characteristics, and looked at characteristics of their primary care practices. We found that practices with extended evening hours had about 20% less ED utilization for their patients. Patients with more Medicaid patients in the practice had higher ED use. And this is a study exclusively of Medicaid patients. So what that means is that if I'm a Medicaid patient and I go into my PCP's office and everyone else in the waiting room is on Medicaid, I will on average use the emergency department more than if I'm a Medicaid patient and I go into my PCP's office and most people there are commercially insured. There's something different about those two practices. Similarly, practices with more patients in relation to the number of clinician hours available have higher ED use. Practices in this study with physician extenders had higher ED use. So now I'm going to talk about the other half. What can we do after the patient seeks ED care? And talk about three potential interventions here. We'll start with ED triage. And here the story is kind of glass half empty, glass half full. The good news is that when you have a triage system in place, and these are much less prevalent now with the prudent layperson standard and EMTALA than they used to be, although under current administration one could see this being resurrected. But most patients survive. The glass half empty is that a small percentage of patients who are triaged out of the ED and followed require hospitalization the same day. And I would argue it's likely that these are the tip of the iceberg. There are a lot of things we do in the ED for people besides hospitalize them, for which their outcomes will be better if that happens sooner rather than later. Now, were it true that the cost of ED care were a major driver of US healthcare costs, or that the ED patient seeking care for problems that could be managed elsewhere was a major contributor to ED overcrowding, you might argue that from a societal perspective, it's appropriate to ask people to take the small risk of having a triage system in place. But in fact, the cost of ED care is a pretty small component of healthcare costs, and most ED overcrowding in the US is caused by boarding of patients who have been admitted to the hospital. Doesn't take very long to manage a patient with a sore throat or a sprained ankle. So given that, to me, it's hard to justify a triage approach. Another potential way that emergency medicine and primary care can work together is facilitating follow-up after the ED visit. This is a study from an inner city hospital that looked at patients presenting to the ED with asthma and tried to improve their follow-up. It was a randomized trial where the intervention group got prednisone dispensed in the ED, cab vouchers to go to the primary care provider, and a phone reminder to make that appointment. And the good news is that there was a substantial improvement compared to the control group. 29% in the control, 46% in the intervention group got follow-up. And the bad news is 46% ain't all that good. A partial explanation for that may come from this second study where simulated patients called several hundred practices around the US with a script saying, I was seen in the emergency department for urinary tract infection, low back pain, and so on, and I was told to get a follow-up appointment promptly. Can you see me? And when those simulated patients said they had commercial insurance, about 2/3 were offered an appointment. Those on Medicaid, only about 34% of practices would see them. Finally, talk about follow-up after hospitalization. This is a review article from last year where the authors cited a couple studies that were shown to reduce readmission, and although they didn't study return visits to the ED, I think the dynamic would be similar. And they found that it enhanced discharge planning and a comprehensive hospital at home approach that provided hospital-level care in the patient's residence were both successful at reducing readmission rates. In general, they found that successful interventions were those that addressed multiple aspects of the care transition, that were not just hospital-focused, but extended beyond the hospital stay, and that were flexible enough to allow creativity in responding to the needs of the individual patient. Masheed asked me to talk a little bit about possible next steps. And in terms of factors that affect ED use, as you can tell, I'm a big believer in the systems level conceptual model. The emergency department utilization is not a problem per se, but a proxy measure of issues elsewhere in the healthcare delivery system. And that lets us shift the focus from blaming the victim to fixing the system. I think there's a lot of potential in the Anderson and a Day model to look comprehensively at potential drivers of ED use and come up with observational research, hopefully leading to interventional trials. And when we get to those interventions, it's going to be important to really think through the outcome variables carefully. It would be a shame to do a study that showed success in substantially reducing ED use, but failed to look at outcomes like subsequent hospitalization, use of ancillary services, patient morbidity, mortality, and cost. And I think we need to look at the big picture. Finally, looking at transitions for people seeking ED care and facilitating those, that's what the ACRU is about. And that's Masheed's vision, and what's so exciting about being in this room with this group of people, that we need exactly this. We need better coordination with primary care, inpatient care, public health, social services. We need that clinically, and we need that in designing and conducting rigorous and clinically important research. There's a long path ahead with an exciting destination. Questions? Thank you.